Welcome, everyone. My name is Dr. Jennifer Phillips. I'm a clinical child psychologist and co-director of the Autism and Developmental Disorders Clinic at Stanford Children's Hospital. I'm very pleased to welcome Dr. Antonio Hardan to speak today about the management of sleep issues in autism. This is the third and final webinar in our series on sleep issues in children being offered by our clinical team in the Stanford Autism Sleep Center. Dr. Hardan is a professor in the Department of Psychiatry and Behavioral Sciences at Stanford University. He is the director of the Child and Adolescent Psychiatry Division and the director of the Autism and Developmental Disorders Clinic. His research expertise is in the neurobiology of autism and in the development of innovative treatments for individuals with autism and other neurodevelopmental and neurogenetic disorders. He has led numerous federally funded projects examining the efficacy of a wide range of treatments in autism and related conditions, including psychosocial interventions such as pivotal response treatment and pharmacological agents such as arginine, vasopressin, N-acetylcysteine, everolimus, pregnenolone, and suvorexant. He is currently the project leader on 3 clinical trials examining the safety and efficacy of 3 medication treatments for sleep disturbances in autism. Finally, he's published more than 170 journal articles and has co-authored several book chapters in the field of developmental disorders. I will now turn it over to Dr. Hardan to talk with us about sleep management in autistic youth, when to consider medications, and what to choose. As a reminder, at the end of this talk, and perhaps as we go, we'll have time for a few audience questions. Please put your questions in the chat as we go, and we'll save time to answer those.
Very good. Thank you, Dr. Phillips. Welcome, everyone. Good morning, good afternoon, good evening. I know people might be joining us from all over. My name is Antonio Hardan. I'm excited to be here today, and I want to thank Dr. Phillips and the team who put together this webinar. First, I want to share a disclaimer. I'm recovering from a cold, so I might need to take a break at some point, or my voice might choke at some time, so I might need to take a minute or two of a break. To facilitate that, what's going to happen is that if after every break, every part, I will allow people to ask questions. That will give me a minute or so to recover. So I'm excited today to talk about managing sleep in autistic youth. It's a problem that we're dealing with every day. As you all know, the rate of sleep disturbances in autistic youth or adults is very high, up to 80%. So let's talk first about the topic that we will be covering today. We'll provide some background on sleep in autism, cover a little bit sleep physiology, talk a lot about available treatment, and share with you the work that we have been doing here at Stanford. So I've been spending quite a bit of my time, whether it's clinical or research, on this topic. So what's the definition of insomnia based on a DSM-4, or sorry, DSM-5? So it's a persistent difficulty initiating or maintaining sleep, and it can manifest either mid-sleep waking or early morning awakening, or even difficulty falling asleep. There is a consequent distress or impairment in daily functioning, and this is a common for all DSM-5 criteria. And what's important also is that the sleep disorder or sleep disturbances are not due to a different disorder such as sleep apnea, restless leg syndrome, or medication. Sleep disturbances can start as early as 2 years of age, and they can become chronic. So why sleep is important? Sleep is key to help the child develop normally, whether physically or emotionally. Sleep is essential for health and different aspect of physical health. It's critical for a healthy immune function, muscle growth, processing emotions, learning, memory. The National Sleep Foundation recommends the following hours of sleep for kids aged 3 to 5. They recommending 10 to 13 hours of sleep. For age 6 to 12, 9 to 12 hours. And for teenagers aged 13 to 18, they recommend 8 to 10 hours. So what are the predisposing factors, or what are the factors that play a role in the development of sleep disturbances? First, we have biologic factors. The first one is genetics. It's possible that there have been some abnormalities in the genes that will control sleep, and the expression of these genes could be altered that will lead to sleep disturbances. There are some other biologic factors such as decreased vagal tone or increased cognitive activity. For example, you hear a lot of parents reporting that the kid cannot slow down even at the end of the day. So there is that drive, that motoric activity that will lead to difficulty settling down to go to sleep. There are some perpetuating factors that will apply to any one of us. The first one is poor sleep hygiene, staying in bed, eating in bed, studying in bed, doing work in bed. Anxiety. If someone is anxious, that's going to affect a little bit their sleep pattern. Also, diet, uh, consumption of caffeine, tea, sleep time that keeps changing, or exercising late at night. Also, disruptive behaviors, non-compliance, oppositionality, defiance that we see sometimes with kids could affect sleep pattern. There are also some ASD factors that will perpetuate sleep difficulties. First one is rigidity, wanting to go to bed at a specific time. Also, involvement in bedtime routines. They need to do 5, 6, or 10 different steps before going to bed. Sometimes communication difficulty, ability to express oneself could be a limiting factor in helping with the transitioning to bed. Moving on to and the importance of understanding sleep disturbances. When you look at the general pediatric population, about 20% of kids do have some form of sleep disorders. In autistic kids, that percentage varies from 40 to 80%. And you're probably wondering why this wide range. A colleague of ours, Dr. Larry Scahill, uh, reviewed reports, parent report from about 1,000 or 1,100 parents. This was a community sample, and they found that about 40% of the kids with autism, they do have sleep disturbances. So when you look at the community sample, 40% is the average number of kids who do have sleep disturbances. Now you move to a general psychiatry practice or general psychologic practice. It's important to realize that the percentage is about 60%. It moves to 80% when you look at a specialty clinic such an autism clinic. So the rate or the prevalence of sleep disturbances will increase depending on the setting. What's the impact of sleep disturbances? If any one of us will have 1 or 2 or 3 nights of bad sleep, this is gonna impact a little bit our attention, the way we feel, and our behavior. We're gonna become a little bit more irritable. When you look at kids with autism who've been experiencing these difficulties for a long period of time, it's not surprising to realize that this poor sleep is going to impact daytime behavior, emotion regulation, and attention. Chronic sleep problems can affect cardiovascular health, your heart, and also endocrine and immune system. And if you have a child within your family that is exhibiting sleep disturbances, it's going to lead to increased parental stress and the well-being of the family. Also, the good thing is sleep disorders and sleep dysregulation can be treated. There are treatment out there for it. Yet, we don't have optimal approaches to treat sleep disturbances in autism. Let's talk a little bit about the phenotypes of sleep disruption in ASD. First, we have bedtime resistance. So this is a refusal or prolonged bedtime routine. The other one is prolonged sleep latency, which means it takes the child a little bit longer to fall asleep. They are in bed, but instead of sleeping within 10 minutes, 15 minutes, it takes them half an hour, 1 hour. And we've heard some kids and some teenagers stay in bed for about 2 hours sometimes. Reduce total hours of sleep. So instead of sleeping for, let's say, 8 hours or 9 hours for a teenager, they sleep for about 5 or 6. Frequent awakening. We all wake up during the night, but we turn and we fall asleep immediately. Some individuals with sleep disturbances, especially autistic kids, they wake up and it's very hard for them to fall asleep. The other sleep manifestation is early morning awakening. We're used to get up at 7 o'clock on average or 8 o'clock. Some people wake up at 5 or 6, and it's very hard for them to sleep. And these early awakening are associated with circadian rhythm dysregulation and irritability. There is also daytime sleepiness, and that's one of the manifestation of sleep disturbances is people feel tired during the day. It leads to naps, fatigues, inattention, and as you would expect, it affects learning, executive function, and attention. Now let's look a little bit at the sleep physiology. I like this graph because it describes a little bit the homeostatic sleep drive. So think about a pressure that mounts over time as the day progresses, with increase in the drive to stay awake, but at some point it starts decreasing and will allow the sleep drive to take over, which will help us to fall asleep. The same thing happened when we were sleeping. The drive to keep us asleep will decrease progressively, and the drive that is pushing us to get up and be awake increase progressively as we're falling asleep. Now, how are these regulated? This is a complicated slide, but think about a balance. You have hormones that's pushing us to stay awake, and some molecules or hormones that's pushing us to sleep. And this balance is critical for having a normal sleep-wake cycle. Think about a car when you have a gas pedal and a brake pedal. A gas pedal will push the car forward and a brake will slow it down. So having a right balance between the gas pedal and the brake pedal is critical for the car to move on. It's some extent a little bit similar. There are several hormones that are involved in wakefulness. One of them is histamine, serotonin, norepinephrine, acetylcholine, glutamate, and dopamine. So some of these neurotransmitters you might not be familiar with, but these are molecules that help us stay awake. If you antagonize the pathways that these hormones are involved in, it's going to lead to tiredness and sleepiness. And that's how medications work. For example, glutamate is an excitatory neurotransmitter. If you give a medication that will decrease the transmission of glutamate, it's going to lead to tiredness and sleepiness. Compound that will modulate or will help sleep, medication that will target the GABAergic receptors or GABAergic pathways such as zolpidem, they will facilitate a little bit the sleep that the individual will be experiencing. Melatonin is very interesting. It's a very mild hypnotic, but its main role is to regularize the sleep-wake cycle. So it's a sleep-inducing agent, but also its main role is regularizing the circadian rhythm. Very good. Let me take a break here, see if we have any questions. Um, let us know if you have any questions about the overall uh, presentation so far about sleep. Do we have any questions, Dr. Phillips?
We don't have any questions yet, but people can definitely put those questions in the chat and we can take them as we go. We do have a quick question about sleep onset. What's the average time for a neurotypical person sleep onset, someone who does not have autism?
Yeah. So usually it's about 10 minutes. We all go to bed on a regular basis. 5 to 10 minutes is the average time that someone will need to transition to falling asleep. Very good. Thank you for this question. Okay. Let's move on to the second part, which is the treatment. The title of the presentation is psychopharmacologic treatment, but before I go into that, I want to highlight the importance of behavioral intervention or non-psychopharmacologic intervention. A good number of kids, autistic kids, will benefit from behavioral intervention. So before we consider a pharmacologic intervention, it's important to make sure that they have received adequate and appropriate behavioral intervention. The way how I look at it is a bird with two wings. On one side, you have on one wing is the behavioral intervention, and the other one is the psychopharmacologic intervention. A bird will not fly with one wing. An airplane will not fly with one wing. So that's why it's important to keep in mind that we need both of these interventions for optimized sleep treatment. Some kids might do very well with behavioral intervention. That's great. Occasionally, we need to consider medication. While we're considering medication, we have always to keep in mind that we need to be implementing behavioral intervention. Here I have a picture of two kids uh, to remind me that one of them, Corey, came to us on 5 different medications, but he was not receiving any behavioral intervention. We pushed and we said, we're not making any change in the medication until there is a good behavioral plan implemented. Will is the other extreme. Will has been or experienced or was put through as many psychotherapeutic approaches as you can think of. And it took the parents about a year and a half before they come to us or they came to us. So we don't want to delay psychopharmacologic treatment if behavioral interventions, appropriate behavioral interventions are being implemented and not effective. So that's why usually when we evaluate someone for sleep disturbances, we make sure that they get a good and appropriate course of behavioral treatment or psychotherapeutic treatment before we consider a medication. Okay. Now, let's look at the American Academy of Neurology, the practice guideline regarding sleep. The only medication that they recommend is melatonin, and they divide it into pharmaceutical grade and over the counter. As you would expect, they recommend pharmaceutical grade. And when you look at the other medication that ironically we're using for sleep, they say it's not recommended because there is insufficient evidence. But there is truth to that. And at the end, they recommend behavioral strategies as being the first line for all ASD sleep disturbances, which is not surprising. So this is to tell you a little bit the not so great state of medication treatment in autism. Evidence for melatonin, but not much for all the other medications. We'll be talking about the other medications, but it will be off-label to some extent. This is a list of the behavioral interventions. I'm listing them. I will not go over them. There are other webinars that cover this topic. But just to remind you, there is a long list of intervention that could be implemented before we get to medications. And as parents or as clinician, you want to make sure that these some of these strategies have been implemented before considering medication. Definitely parent education is reasonable and it should be standard for all parents of kids with autistic disorder or non-autistic disorder, but they do have sleep disturbances. Positive bedtime routines, extension, gradual distancing, where the parent gradually increase the distance to the child. This is a common problem we see where kids want the parents to be in the same room. So what you do, the first period of time, the first few nights, you stay next to the child, then you move your chair by about, let's say, 1 foot a week, progressively away from the bed of the child to the point where you will end up outside, sitting outside, and then hopefully not around the room. Sleep restriction therapy is also another strategy. Bedtime fading is also another approach we use. Scheduled awakening. This is for individuals with night waking up or night terrors. So you wake them up 30 minutes before the time. They usually awaken spontaneously. Chronotherapy is moving the bedtime and rise time later and later each day until the child is sleeping on a normal schedule. We see that um, on a regular basis. The kid likes to go to bed at 6 p.m. but wakes up at 1 a.m. or 2 a.m. So this chronotherapy is a strategy to deal with this process. And also there is a bedtime pass where some kids keep asking for favors at the end of the night. I want a kiss. I want you to read for me. I want you to sit next to me. So you can develop a strategy where they get only one bed pass, which is one request around bedtime. Let's move on to serotonin. So uh, serotonin is a hormone that has been implicated in autism. There are a lot of evidence supporting abnormalities of melatonin, and its role, as I mentioned earlier, is to help us regulate our sleep-wake cycle with regard to light. And the peak secretion of melatonin is in the middle of the night. So there is evidence that there is reduced melatonin level in kids with autism. There is lower nocturnal and daytime concentration measured in plasma or in urine. There is a blunted circadian rhythm in ASD. As I mentioned, there is a peak that happens at night that sometimes is flattened, and sometimes there is inverted melatonin rhythm with maybe peaking, with melatonin peaking during the day instead of middle of the night. There is evidence that there is an impaired synthesis with decreased activity of the enzyme that metabolizes melatonin. If you can see on the right hand side, you start with tryptophan, which is an amino acid that is metabolized in 5-hydroxytryptophan, that's metabolized in serotonin, then metabolized in N-acetyl serotonin, and then eventually to melatonin. Tryptophan at some point has been used as a supplement to help with sleep, and this is the rationale, because if you supplement with a little bit more tryptophan, it will end up becoming melatonin. So, what's the impact of all of these melatonin abnormalities? So we see that these abnormalities are correlated with sleep onset and maintenance problem, altered sleep-wake cycles, either shifting to later sleep or earlier sleep, and greater autism symptom severity with social communication and adaptive ability. So this is the background of the melatonin. Now I'm going to go over the studies that looked at melatonin and showing that it's helpful. So this is the summary. So I looked at two meta-analyses. Meta-analysis is a group of studies that put together and analyze to see whether they show the same conclusion. So we have one study that looked at 8 articles looking at the treatment, at melatonin as a treatment, and another one that looked at 16 articles. What they showed is there's a reduction of sleep, but when you give melatonin, there is a reduction of sleep latency by an average of 30 minutes compared to placebo. The total sleep time in bed increases by about 60 minutes, improved in sleep efficiency. So the time you spend in bed is actually sleeping, not tossing and turning. There is a decrease in WASO, which is waking after sleep onset or sleep continuation difficulties. The dose ranges in these studies go from 0.5 all the way to 25 milligrams and given 30 to 60 minutes before bedtime. The optimal efficacy of these doses is around 5 to 6 milligrams. And clinically, that's what we do. Like I rarely go above 6 milligrams, usually start 1 milligram a day and progressively increasing it every few days or on average every week up to 6 milligrams. Efficacy of melatonin is mostly clear in kids age 10 and older. You can use the immediate release melatonin for kids with sleep onset insomnia, and prolonged release formulation may help with sleep maintenance. Now, the question that comes to us is, would improving sleep with melatonin, does it help with daytime behavior and the adaptive ability? Unfortunately, there is no science to date supporting that these the use of melatonin does help with daytime behavior and improving the quality of life of the child and the family. It does not mean that it doesn't help, but whatever evidence we have right now does not support that. As we talked, there are two types of melatonin. The one is the pharmaceutical grade that we require a prescription, and the other one is that's available over the counter. So the pharmaceutical grade melatonin and prolonged release formulation are preferred to minimize variability. Overall, melatonin is very well tolerated with no serious adverse event. Some parents in studies and also clinically have reported mild symptoms such as drowsiness in the morning, fatigue, somnolence, mood swings, increased enuresis, which is bedwetting, headaches, dizziness, diarrhea, rash, and at times hypothermia. From what we know in the studies, there is no evidence of negative impact on growth, body mass index, or pubertal development over 2 years of follow-up. However, we have some children in the clinics, or we were aware of, that have been on melatonin for years. So that's why long-term safety, like beyond the 2 years, they are very lacking. There is also a theoretical concern that melatonin could affect pubertal effect, and the absence of robust long-term safety studies in pediatric population drives us to reassess the need for melatonin every now and then to make sure that the child is still benefiting from it. So if someone is benefiting from it, that's great. You prescribe it for a period of time, but then you identify a period of time, usually over the summer, and you have to try to decrease it to see whether still need it or not. So this is the last slide before the next break, which is looking at sleep disturbances. This is kind of a guideline for us clinician, but I think it will be very helpful for everyone to be aware of that. So first, prior to considering medication, you have to complete a sleep log and or a questionnaire called the Sleep Habit Questionnaire for children. Then you have to assess potential things that could be contributing to the sleep disturbances. Is the child on the medication that could affect sleep, such as, sometimes antidepressants can cause that. Caffeine can cause sleep disturbances. Sometimes disordered breathing, such as apnea or snoring. Restless leg syndrome. Chronic iron deficiency or magnesium level. So that's why it's important sometimes to check that. Nocturnal enuresis can affect sleep. Gastrointestinal problem could affect that. The gastroesophageal reflux, if somebody has a reflux, could affect their sleep, and it's associated with uh, waking up during the night. Seizure activity, anxiety, depression, ADHD, or unrecognized pain and discomfort. So that's why it's important to rule out these contributing factor, at least think of them. And then once you do that, once you clear out these or you rule out these issues, you take them in consideration, you do a very important behavioral intervention such optimizing sleep hygiene and encouraging the individual to participate in exercise not around bedtime. And once all of these strategies fail, then you can consider melatonin. Very good. That's another part that I wanted to cover. So let's see if we have any questions. Dr. Phillips?
Yes, we do have quite a few questions. I think they're good ones. Um, Kind of going back to some earlier slides, you had a slide that talked about how even though we know that we can treat sleep issues, there aren't any just treatments for sleep disturbance and autism in particular. But as you've walked through some of the additional things that we can implement, do you want to just say a little bit more about what you mean when you say there aren't any treatments out there for autism specifically?
Uh, with regard to medications?
I think it was a general comment, but I think that maybe the way I interpret it is that it's about autism specifically versus what we know about treating sleep in general.
Yeah. So I think from behavioral point of view, there have been some studies that have looked at behavioral interventions specifically for autistic kids, psychoeducation, 2, 3 sessions of sleep. So that's been clearly evident. For medication, we'll review that in the next part, which is ironically very straightforward. Unfortunately, beside melatonin, there are no randomized control trial looking at any other sleep agents. And that's part of what we are trying to do here at Stanford is to do some control trial to help guide us whether there are some medication that are effective or not for autism.
And thinking about melatonin, there was a question about younger children, like children who are 5.
Mhm.
Um, as far as, using melatonin in that age and maybe what the best dose would be, you had mentioned the, 5 to 6 milligrams. Is that the same for those younger children?
Yeah, usually would start at a very low dose, start low and go up slowly. We can start with at like a 5-year-old at zero point 0.5 milligrams. And if you can find it, because sometimes it's very hard to find the zero point 0.5. Ironically, the most popular dose out there is 3 milligrams. I take melatonin myself when I travel, and it's very hard for me to find the 1 milligram. And that's why I recommend in terms of trying to look around to find a lower dose and starting a lower dose. There is no clear cut that a higher dose will make a big difference. As I mentioned, the goal is to start low and get to 5, 6 milligram maximum. Most of the kids that I recommend melatonin, they end up around this dose. Occasionally, we'll get someone who's with 10 milligram who is on 10 milligrams or higher. I don't have anyone in my practice right now with over 10 milligrams. I have maybe one or two with 10 milligram, but most kids are around from 1 to 5 max.
And if children have other conditions like Ehlers-Danlos syndrome or POTS, in addition to autism or ADHD, are the recommendations the same as far as these melatonin, the different sleep interventions.
Yeah, it's more of a clinical recommendation. It's not based on hardcore science. Yes, we recommend to start with a low dose and go up progressively. Very good. So maybe we can move on to the next
Yeah.
part. Very good. Thank you. It's great to see a lot of questions. That's exciting. That means that everyone is paying attention. So that's good. Okay. So let's uh, move on. Now we move on to the other medication. So as you can see here, there's a list of different medication that we use. And unfortunately, there is no science to support or to guide us a little bit. It's basically mostly our clinical practice. The first one is antipsychotics. What's listed here is olanzapine, risperidone, and Seroquel quetiapine is the third antipsychotic that's sometimes used because these medications they are sedating and sometimes we use them. However, because of their side effect profile, we try to stay away from prescribing them, except if there are any comorbid conditions such as aggression, severe mood dysregulation. Another medication that's commonly used is trazodone. Here it's listed, the dose is between 20 and 50 milligram, and I will show you on the next slide that some other people recommend actually up to 150 milligrams. It's an antidepressant. It helps with depression, but also because of its sedating profile, we have used it for the treatment of uh, sleep in kids with autism. We use it quite a bit in adults, but we've used it also in kids. The most popular drug used for currently for sleep, after melatonin and prescribed medication is clonidine. It's an alpha adrenergic agonist. Uh, it's been shown that it helps with sleep initiation and maintenance of insomnia. The recommended dose here is 0.05 to 0.225. On the next slide, other people have used it all the way to 0.3 milligrams. And it has side effects. One of its main side effects is sedation. That's why we use it. But also it can lead to hypotension, mood dysregulation, dry mouth, REM suppression. But despite that it can cause these side effects, we currently use it because overall is very well tolerated. And by the way, listing the side effects does not mean that the child will experience these side effects. These are potential side effects. Another group of medication is antihistaminergic. Remember, histamine will keep you awake. So if you block that receptor or you modulate, downregulate that pathway, you're going to lead to some sedation. Diphenhydramine and hydroxyzine are a very good example here. Diphenhydramine up to 25 milligrams, sometimes a little bit higher in teenagers and adults. And it helped because of its sedation, because of the histaminergic, and it's also a cholinergic. And acetylcholine is um, awake neurotransmitter. So if you block both histamine and cholinergic acetylcholine, you will lead to sedation. Another group of medication are the sedative and hypnotic benzodiazepine. Called one of them is clonazepam or Valium, diazepam, or triazolam, halcyon. Uh, they their side effect is sedation and headaches, and that's and because of the sedation, that's why we use them. They are controlled substances, so they have a risk for addiction. So that's why we don't use them as first line. Um, they do have their share of side effects. That's why they have to be used carefully. Iron supplement, we discussed a little bit that iron deficiency can lead to sleep. I don't have a lot to sleep disturbances, and I don't have a lot of experience with it because usually it's managed by primary care physicians. Uh, my challenge with iron is that it leads to side effects and it has a unusual taste, so that's why we want to be mindful of that. The last medication I want to cover in this slide is the uh, donepezil, which is an Alzheimer drug that's been used in one study to assess its impact on sleep. And ironically, it has a very positive impact. One is it helps with REM sleep by increasing REM sleep, because in autism, there is some evidence suggesting that REM sleep is lower than average. So it increases REM sleep, and also it decreases REM latency, which means that it help with sleep onset. It's not commonly used because it's not a very strong hypnotic, but when you think about normalizing sleep, it's tempting to think about considering using donepezil or Aricept. This is another slide going over the same medication by a different group. This is a little bit more recent. And we talked about melatonin, clonidine, trazodone, hydroxyzine, guanfacine, which is very similar to clonidine. I want to mention mirtazapine, Remeron, which is an antidepressant, kind of a cousin to trazodone, but it's very sedating. And we have used it in targeting sleep. And ironically, it does help with some disruptive behavior during the day. Another medication is zolpidem, Ambien, which is a GABAergic medication. Remember, GABA facilitates sleeps. It leads to drowsiness, and that's the desired effect. However, it can be associated with dizziness and diarrhea. The last medication is amitriptyline, which is a tricyclic antidepressant. It's sedating, but it does have a good share of side effects such as dry mouth, constipation, and we have to monitor heart when we prescribe this medication and can potentially lower the seizure threshold. So we don't use it as much, but it's an option. Now, all these medication, there is limited scientific evidence supporting that they work, but clinically we use them and we feel that they work. The other last two medication I want to cover here is gabapentin, which is a modulator of the calcium channels, and it does not affect GABA receptor, but it's very sedating and can be used for sleep. It's Neurontin. Some people with back pain, they've been prescribed this medication at night because it helps with sleep, but also it helps with sensory processing. The last medication is doxepin, which is very similar to the tricyclic. It's a combination of targets serotonin and norepinephrine. It helps with sleep, and it has been used on a regular basis with some kids with good effect, but we'll have to monitor the heart rate with that. Now, this is kind of outside the box to tell you a little bit how people are experimenting with different treatment for sleep. Here we have the transcranial magnetic stimulation. These are two studies looking at the effect of different types of transcranial magnetic stimulation, showing that potentially it could be helpful for sleep. Now, using TMS only for sleep, this is like a complicated process because you need to come to a clinical facility every day, 5 days a week for about 6 to 8 weeks. So it's very problematic or very time consuming. Let's look a little bit at the slide here. What happens after melatonin? So depending whether you want to treat sleep onset, based on this algorithm, you go consider clonidine, trazodone, or hydroxyzine. Or if you want to target maintenance, you use melatonin extended release, clonidine extended release, guanfacine extended release. If the patient can swallow a pill. If you have not tried, at some point you can try trazodone, mirtazapine, hydroxyzine, and if these fail, you move to zolpidem. Now, this is an algorithm put together by these investigators, Minter and all, but it's not based on scientific evidence. Very good. Let me continue here, since my voice is holding a little bit. This is talking a little bit about the studies that we are doing here at Stanford. because of the interest in sleep by the community and our interest also, we submitted a large grant and fortunately we got funded. It's a Stanford Sleep Autism Center of Excellence with three components. Project one is looking at 150 kids with ASD and 75 control, and we do in-home polysomnography and actigraphy, and we look at the relationship between sleep and autistic behaviors and uh, other type of psychiatric symptoms. Project two, it consists of three trials. The first trial is diphenhydramine, targeting histaminergic transmission. The other one is suvorexant, which is targeting the orexin receptor antagonist, orexin receptors. And remember, these are the medication that keep us awake. So if we block them, will lead to sedation. And the third medication trial is zolpidem, which is a GABAergic agonist. And we are recruiting for both Project 1 and Project 2. And the third project is looking at sleep in fish. It's zebrafish in particular. And this is a little bit all the different measures that we are collecting. We're collecting them in Project 1, Project 2, and Project 3 in fish. And the idea is to see how our sleep is similar compared to fish, and when it's abnormal, how is it abnormal in fish? And in the bottom part of this slide, you can see that the same medication that we're using and we're trying to study in humans, we're studying them in fish to see whether there is a differential impact. This is looking at the relationship of sleep disturbances and different autism symptomatology. It's very related. The worse your sleep, the worse your autism symptoms. Now, this does not infer causation, it's association. So the worse your sleep, your social abilities are, the worse your sleep, the worse your restricted repetitive behaviors are, the worse is your sleep. Here looking at sensory, again, the same profile, different type of sensory domains. The worse you have sensory sensitivity, the worse your autism, your sleep is. The worse you're avoidant of sensory sensitivity, the worse your sleep is. We also looked at relationship of sensory and sleep physiology, and we noticed that only waking up after sleep onset is correlated with touch of sleep, with tactile sensory abnormalities. We talked about the three different trials here. Let me show you a little bit the design. We recruiting for three trial. It's a 8-week design, double blind crossover. We start with 4 weeks. The individual could start either on the active or on the placebo, and they switched in the next 4 weeks. So far in the diphenhydramine trial, we've had 15 participants completed the study, and maybe some of you have been part of these studies, so thank you. And the age range is 8 to 17 with a wide range of full scale IQ from 53 to 120. And we're trying to get severely affective individual because in general, they have more severe symptomatology for autism. They need to have some sleep disturbances and getting some form of sleep physiology, whether it's a polysomnography or actigraphy. This is too much information here for you, but this is the assessment that we do at baseline week 4 and week 8 every time we switch. So this is the inclusion criteria. Again, a lot of information here, but because it's a research study, people will have to be very specific with regard to the different profile that we have to include in these studies. These are the exclusion criteria. People who are on benzodiazepine or taking anti-epileptic medication for seizure, they cannot be part of the study. Let's look at the preliminary results. This is looking at people who are on the placebo arm just to see whether being part of a study will change their sleep habits or their sleep physiology. Unfortunately, no. Most people who participated in that did not show any variability with the placebo. We're seeing some variability in the sleep efficiency, and we're gonna monitor that once we have more participants. Now, looking at sleep physiology, the impact of diphenhydramine on sleep physiology, sleep efficiency, and sleep onset and sleep latency. This is as measured by actigraphy and polysomnography. And interestingly, we don't see any impact there. We also look at uh, waking after sleep onset and total sleep time. And ironically, we don't see improvement with diphenhydramine. It's a little bit puzzling, but we're still conducting the study. Interestingly, we see benefits based on parent reports in sleep duration and the total score of the Child Sleep Health Questionnaire. So clinically, we're seeing benefits, but not when we look at the sleep characteristic and sleep physiology. It's possible that the sample size is small. That's why we're not seeing benefits on sleep parameters. And maybe when we can get more participants, we'll be able to do that to see the signal there. Or it's possible that it's helping sleep, but we're not capturing that in the physiologic measure that we are collecting. So let's summarize. First, if you have sleep disturbances, consider behavioral therapy first. There is strong evidence for melatonin, limited evidence for other medications. When it comes to our studies, we have several ongoing medications trial. There is potential benefit for diphenhydramine. For the other one, we'll have to wait until we get more data. And for sleep physiology, we'll have to wait also for more participant uh, in the diphenhydramine trial. And here, from a scientific point of view, there is a great opportunity for progress when we look at sleep disturbances. First, it's very common. Sleep physiology is well studied. We know how to study it. And there are a lot of hypnotics out there that's worth investigating. And here, this is a list of medication that have been studied in adults, but not in autism, like in adults with sleep disturbances. And we have not studied them in autism. And we talked about these different groups. But this is to illustrate that there is guidance in the neurotypical literature with sleep and for individuals who are neurotypicals and with sleep disturbances. And there is an opportunity to study that in the field of autism. Some of the research work cannot be done only by one person, that we have a group of people. I want to acknowledge Joachim Hallmeyer, who's the lead investigator on the project, and definitely all the research team and research member who made this happen. Before I take any questions, I want to just remind you for this steep study that we are doing. One is the observational study and the medication trial. We are recruiting for that. We are not recruiting for the fish study because Dr. Morin, Philippe Morin, who's one of our colleagues, has already the fish in the lab and he's studying their sleep pattern. This is the patient that we are looking at, the kids with autism age 4 to 17, diagnosed with autism. We're also looking at neurotypical kids, typically developing kids, to compare the findings in autistic kids with the typical kids, typically developing kids. You can take a screenshot of all these studies that we're doing on sleep in English and Spanish, the medication study, and some behavioral studies for sleep. And on that, I will end, and I want to thank you all for your attention. And we have few minutes to answer 2, 3 quick questions.
We've had so many great questions. I'm going to try to summarize two kind of themes that I was seeing come up in the questions, and unfortunately, we won't get to everything. But there were a lot of questions that centered around just kind of age of the use of different medications. I know we talked a little bit about that with melatonin, but also kind of commenting on how in our study we're doing the medication trials in older children. Could you say a little bit about just what's the lowest age for some of these different medication options of when you would consider a medication?
Yeah. Unfortunately, we've considered some of these medications, let's say clonidine, benzodiazepine like lorazepam in preschoolers. I don't like to do that, but at times when you have a kid who's sleeping 4 or 5 hours and when they wake up, they wreak havoc on the house. They wake up, they're at risk of running uh, outside the house or waking up all the household, the sister, the brothers, and the parents. We have unfortunately to be aggressive and prescribe medication, but after making sure that they received a very good behavioral intervention. We don't like that, but unfortunately, sometimes our hands are tied because we need to create a living environment for the family.
The other questions, there have been a few questions coming back to something that in one of your early slides, when you went through some of the different neurotransmitters that we know are implemented in kind of impact on sleep, and people were asking about how you would know, is there a test, a way to find out like kind of what to target? Would there be a genomic test to look at the clock genes or, some of these ways that you could maybe zero in on what the actual problem is?
The easy answer is I wish we have something like that. And that's part of what we're trying to do. We're trying to do is collect actigraphy and sleep physiology to see whether people who have some physiologic patterns will be more likely to respond to these specific medications. We're not there yet with regard to genes, like identifying some like clock genes abnormalities, whether they will help them respond to some medication or measuring neurotransmitters. We've done a lot of measurement neurotransmitter in psychiatry, but unfortunately with limited success. We have not done it in the field of sleep, so that's why it's unlikely we'll do it. We're more likely rely on sleep physiology pattern to determine maybe what medication we can consider. That's at least my thinking at this time. It might change after we complete the studies.
Thank you again, Dr. Hardan, for sharing this really valuable information today. That's all the time that we have. Sorry that we couldn't get to all of the questions, but please visit our Stanford Autism Sleep Center website for more information, and the link is in the chat. Thank you so much.
Very good. Thank you everyone for attending and for the great questions. Bye bye.